Okay, so I wanted to share something that showed up on the RACGP News GP. This was emailed to me, and it's fascinating because it represents one of the challenges that we are dealing with in general practice, but also that psychiatry is facing. Now, for whatever reason, we are seeing a massive increase in mental health. This may have been due to COVID. This may have been due to financial strain. This may just be people are not designed or not coping well with the reality that we are faced with, this fast-paced, highly technological social media world, and people's minds without structures are not doing well. And so that is leading to this boom in mental health. Now, we're at the forefront of that in medicine. People are coming to us, hey, what do I do? I'm anxious, I'm depressed, I'm struggling, I'm addicted. We're seeing the consequences of these things. And then when we go to the psychiatrists, we're finding that their books are full. Their books are full. They're like, hey, we've got an option in 9 months' time. We've got an opening in 6 months' time. Or, as this letter goes through, hey, we're not taking that particular type of patient. We're only going to take our type of patient that we want to deal with. And this has advantages. Remember that from a marketing perspective, a subspecialist, a psychiatrist who only sees ADHD or only sees a particular disease is more valuable. That's all they're doing. They're a subspecialist in that. And so the consequence is, though, if you've got other things that need to be seen, they're not available for it. So, question mark, what are we going to do? Well, here's my suggestion. Most of my experiences in working through the challenges that I've had use structures, use a series of questions that are asked. Now, I brought this up with a psychologist friend of mine, like, how about we just systemize psychology? And they said, look, they've tried. But what happens is by the third question, it diverges into so many different possibilities that's why the psychologist is there. That their guide, they're like, oh, okay, well, I think we need to go down this path, or I think we need to go down this path. Now, this has not been my experience, though. My experience has been, hey, here's a situation, and we're going to ask a series of questions. This largely for me has been through men's work. Both Mankind Project and Wake Up Warrior have these tool sets. It's like, hey, well, in Mankind Project, what was the agreement? Did you keep the agreement? What was the consequences on you? What were the consequences on others? What's the part of you that allowed you not to keep that agreement? And then so down, 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 down. Same question sets every time. Outcome wildly different depending on the particular agreement that man had. Over in Wake Up Warrior, we've got a different set of questions. It's like, hey, what triggered you? What are the facts about that trigger? What are your emotions about that trigger? Is this what you want? Yes or no? If this is it working? Yes or no? And again, these series of questions. And this may well be something that we need to look at. If we can't get into psychiatrists and general practice is running low on solutions, that we keep seeing the same patient over and over and over and over and nothing's changing. And that's why we're referring in the first place. What are we going to do? My thoughts? Hey, maybe we should use some of these structured systems to actually go through. We could run trials. Hey, let's put them through this series of questions. Let's put them through this series of questions. Let's put them through this series of questions. And this could either be on demand. Okay, there's a situation. I want you to run through this particular set. Or this might be my training. Do it daily. Irrespective of what's going on, you just go through it. When things are good, great. You extract something. When things are bad, you already have the patterns to keep going. My father died like 2 weeks ago, and I just kept going. And it's been very difficult. If you haven't had a parent die, it is extremely difficult. And I judge myself to be relatively competent. I got kids, I'm married, running a property, running medical, like there's a lot going on in my life. And still, it was a big hit. And it was expected. My father had late stage dementia. Probably 2 years, it's been where he's barely been able to say a word. So it wasn't unexpected, but it's still a big hit. So if we can't get services and we can't deal with the changes, then what are we going to do? We've got to look to automation. Now, can ChatGPT do this? It can. You tried this yet? You can ask ChatGPT to act as a therapist and it will ask questions. It's pretty wild. Pretty wild. So we may solve it that way. I know whether you've recommended that. I'm not sure whether that can be recommended. May not be much evidence for it yet, but in a patient who is desperate, like literally it's free. You just got to log on and say, please act as a therapist for me. Please do cognitive behavior therapy for me. And then it will ask a series of questions and you answer them, and then it will give you a customized question, just like a therapist. But if we don't know that that's an option, then we aren't recommending it. Or if it's not safe within the frameworks of legality in terms of recommending that, then that's a problem as well. But if it's going to be 6 months, 9 months, 12 months to get into a psychiatrist, and in the meantime we have to buy time, then this could be an option for us. These structured series of questions. And should you do it yourself? Absolutely. You should try these out. Don't recommend things that you don't do yourself. Have I been through both Mankind Project and Wake Up Warriors series a bunch? Yes, absolutely. Do I know where they go? Yes, I do. Do I know where I can trap myself and trick myself? Absolutely. Shouldn't recommend things that you don't know. Now, obviously in medicine we have a problem in terms of we see diseases that we have not had, and we have to take the knowledge from others. But in terms of going through these structured questions, should you do it? Absolutely. There's not a lot of downside. Not a lot of downside. And you will be an authority when you say, hey, what I think you should do, given we can't get into a psychiatrist for 9 months, why don't you go and do this in the meantime? And what you might find is that they no longer need the psychiatrist, which is pretty wild. I wonder where this is all going. We are under deep forces of change. But the ability to have multiple deployed tool sets that can go and help people at once, very, very, very powerful. All right, that's going to leave you there with that idea. I was going to read this actually. You know what? Let's read it anyway. Jump in there. Okay. To my respected psychiatry colleagues, firstly, I want to thank you for the hard work and dedication you have provided to some of our most vulnerable patients. I can't imagine what it's like to deal with the massive uptake in patient referrals, emergency presentations, increased complexity in diagnosis and treatment. Likely the stress that this can lead to and the pressure you must be under in both the public and the private sector needs acknowledgement. However, we're all on the same journey, and with mental illness prevalence surging in Australia right now, it can sometimes feel like we're fighting a losing battle. In general practice, we're seeing escalating levels of risk, more acute crisis situations, longer consultations, ADHD presentations, eating disorders, increased self-harming behaviors, higher rates of drug use and social problems, more anxiety, and a huge demand for appointments with a general sense of stress and burnout in patients of all ages. Woo! Okay, we got some problems here. So it was within this context that I wish to raise a few concerns that have become the norm in my experience when referring patients to psychiatrists over the past year or so. Below are the top 5 responses I've received to recent times, all of which were part of a generic rejection letter. The psychiatrist does not accept referrals for patients with a history of ADHD, autism, eating disorders, personality disorders, PTSD, and so on. Like, that is psychiatry. So, interesting. The psychiatrist doesn't accept referrals for patients under the age of 15, 16, 17, 18, or vice versa. They don't accept referrals for patients over 15, 16, 17. The psychiatrist doesn't accept referral for a patient with a history of suicide attempts, recent hospitalization, or who is currently at risk. Now, presumably this is a defensive mechanism to prevent any question mark on whether they were at fault. I get it, but it kind of is the job. It's like, hey, well, I'm not going to take anyone who might suicide. Interesting, because obviously psychiatry has that part of it. Psychiatrists will see the patient once for an assessment, but not prescribe or send the patient back to GP, prompting a subsequent search for another psychiatrist. This has been an ongoing complaint within the GP Down Under groups that people will refer, but the psychiatrist won't prescribe. And then we're left in these strange places where some states, like New South Wales, you have to apply for authority to prescribe the medications, but you can't as a GP. And then it's like, okay, well, great. Now what? The group of psychiatrists have reviewed your referral and don't have any suitable something for your patient at this time. Appointments, I presume. Then at the bottom, please you inform your patient of this outcome. I need to say, these letters leave me with mixed feelings, confusion, frustration, helplessness, and ultimately sadness for the patient who deserves better care. These people who know well and for whom we have used everything in our general practice toolkit to manage. At this point, we've usually already tried first, second, and third line treatments to avoid the need to refer. We've hit a wall, and so has the patient, which brings me to my point. I know you're busy, but why are we getting these answers? Whether the books are full or the psychiatrists subspecializing, there we go, that's what I was talking about. I feel GPs need to understand why this is happening and how we can work to help you so that we can help us. When I receive rejection letters, I often ring specialist rooms to explain the importance of getting help, to advocate and explain the urgency. I'm not going to lie, by this point I'm frustrated, but the hardest part is having to explain it all to the patient. Often deflated, naturally feeling their own mental health diagnosis is part of the problem when it comes to getting help. Now that is a significant challenge right there. You're anxious, you're depressed, you're struggling in life, and you can't get specialist help. I like to write detailed referrals for all specialists, make it easier and reduce the need for doubling up work. However, talking to colleagues, perhaps providing a level of detail is actually to our advantage, and a dumbing down of referral would have more chance of getting accepted. Oh, well, yes, interesting idea. But I suppose it's like damned if you do, damned if you don't. Would you allow us to be heard that we can get help when we need it? Is psychiatry now a subspecialized field similar to orthopedics, whereby we cannot see anything even remotely outside their scope of practice? These are questions that come to mind as I grapple with these ever-increasing challenges. In any case, I hope this letter helps you see things from our side and leads to solutions, whether it's greater use of the Medicare Item 291, allowing a one-off visit management plan, or more license of telepsychiatry services, at least in the interim, until more specialists become available to help the workforce. I'm not trying to complain. I have many psychiatrist friends and respect them highly. Rather, I want to understand the situation, what we need to do so we can work together and make the lives of our patients easier. Very interesting. Very interesting. So, I mean, it seems such a generalized problem that there's just way too much work. We haven't got enough psychiatrists. Do we import them? Possibly. Do we go virtual and go to the States or go to the UK? But it's likely that they have similar problems as well. So my thoughts are we're going to need a distributed system of perhaps tested questions that we can take patients through that are done on the computer, that the questions are standardized and the answers that they give are helping themselves. At least it's an interim, at least it's an option. I don't know what the medical legal implications are, but certainly this situation does not seem to be getting better. All right, that's all I got for you today. I'm going to go and drop some needles into patients. Medical acupuncture, extremely helpful for mental health conditions, and I hope you're having an awesome day. Catch you next time.